Hi everybody and welcome to our module on necrosis. In the video on cell injury, I talk about necrosis. It's one of the forms of cell death. The other one is apoptosis. And in necrosis, the cell membrane is lost and cellular contents leak out, and this elicits an inflammatory response. In this video, I'm not going to talk about the cellular changes of necrosis, but I'm going to talk about what happens in the tissue beds that undergo necrosis. Necrosis rarely affects a single cell. It usually affects multiple cells and entire tissue beds or even entire organs. For this reason, there are a number of classic gross and microscopic changes that you can see in tissues undergoing necrosis, and that's what we're going to focus on in this video. Tissue that's undergone necrosis is examined by pathologists in two ways. First of all, they look at the gross structure of the tissue bed that's undergone necrosis, and secondly, they look at specimens under the microscope. Based on those gross and microscopic findings, necrosis can be categorized into a number of types. The two major types are coagulative and liquefactive, and we'll talk about those in this video. There are also some less common types, and these include caseous, fibrinoid, fat necrosis, and gangrenous necrosis, and we'll also talk about all of these. But the point to understand is that these are all determined based on what the tissue that has undergone necrosis looks like, either grossly or under the microscope. We'll start by talking about coagulative necrosis, which is the most common form of necrosis. The hallmark of this form of necrosis is that the tissue architecture is maintained for several days, and this is a key point. The tissue does not just fall apart, but it maintains to some degree its original shape and architecture. The reason this type of necrosis occurs instead of some other type is because the injury that causes cell death and necrosis also damages cellular enzymes. And this is the major distinction between coagulative and liquefactive necrosis. When the enzymes are damaged, there's limited proteolysis because the enzymes are gone from the cells. As a result, much of the tissue shape and architecture can remain intact for several days after necrosis begins. During this time, there is phagocytosis of the cell remnants. This takes a while, and as this is going on, the tissue will maintain its normal architecture. When you examine an organ or a gross specimen that has undergone coagulative necrosis, the main feature is that it's very firm. That's from the influx of inflammatory cells. When you look at the tissue under the microscope, the architecture is preserved, but the cells have been damaged and they've lost their nuclei. There's a red-pink color when you use H&E staining, and that's because the damaged cells take up more stain because their membranes are destroyed. And you will also see an influx of inflammatory cells. This slide shows an ischemic infarct of the kidneys. You can see this white pale area. That is an area undergoing coagulative necrosis. If you could touch this kidney, you would see that this area is relatively firm compared to the rest of the organ. And that's the gross finding in an organ that has suffered from coagulative necrosis. Under the microscope, what you see is that the tissue architecture is maintained. So on the left side of the screen is a normal heart. On the right side of the screen is myocardial tissue after an infarction. And you can see that you still see the wavy lines of the myocytes. The tissue architecture is somewhat preserved. You also see lots of these little dark purple spots. Those are the nuclei of white blood cells which have infiltrated the area. But importantly, this area of the heart has not been completely liquefied or destroyed. If that had happened, we would have a different type of necrosis. So the classic causes of coagulative necrosis are infarctions or ischemia. This is what you see in the myocardium. When there's myocardial ischemia, you also see it in the kidneys and the spleen, when either of these organs suffer from ischemia and poor blood flow. The one exception is the brain. For reasons that are poorly understood, the brain does not undergo coagulative necrosis. It undergoes liquefactive necrosis, which we'll talk about next. So that's a nice segue into liquefactive necrosis, which is the second type of necrosis. And usually this is caused by an infection. So abscesses, like bacterial or fungal abscesses, can destroy a tissue bed, and what they leave behind is an area of liquefactive necrosis, not coagulative necrosis. The one non-infectious place where you can see this is in the brain, as I just mentioned. The reason why the brain undergoes liquefactive necrosis is poorly understood. The cause of liquefactive necrosis in infections is that inflammatory cells are drawn in and the tissue becomes liquefied into a thick liquid mass. That's why it's called liquefactive necrosis. What destroys the tissue are enzymes from the microbes and also enzymes from the lysosomes of dying cells. Like I told you earlier, in this form of necrosis, the cellular enzymes are intact and they can destroy the tissue, as opposed to coagulative necrosis, where the cellular enzymes are often destroyed as part of the necrotic process. When you examine an organ or tissue that has undergone liquefactive necrosis, what you see grossly is just liquid or pus, or maybe just a cavity that's left behind. Microscopically, what you see are numerous neutrophils and the tissue architecture has been destroyed. So here's a picture of an area of the brain that has suffered a stroke, and you can see it's just a hole. The tissue has been liquefied, it's basically gone, and that's an example of liquefactive necrosis. And here's what the brain looks like after a stroke under the microscope. You can see this large area here where the tissue has just been destroyed. There's nothing left. It's got inflammatory cells. It's also just got a lot of empty spaces. The underlying tissue architecture is no longer present. So coagulative and liquefactive necrosis are the two main types of necrosis, but what I'm going to talk about now are some less common types that you generally see only in specific situations. And the first type is caseous necrosis. The word caseous means cheese-like, and that's because grossly this type of necrosis looks like cheese. I'll show you a picture of it in a minute. You rarely see this outside of a tuberculosis infection. Caseous necrosis is the classic finding in an organ that has been infected with Mycobacterium tuberculosis. The reason this occurs is because mycobacteria are very resistant to digestion by phagocytes. For this reason, macrophages are chronically stimulated and they form giant cells and go on to cause granuloma formation. And I talk about this in the video on granulomatous inflammation. In tuberculosis, there's generally a slow breakdown of infection for all these reasons, and lots of the mycolic acid from the mycobacteria and other lipids accumulate, and this is what gives the organ a cheese-like appearance. When you examine an organ that has undergone caseous necrosis, what you see grossly is a cheese-like caseating substance. I'll show you a picture of this in a minute. Microscopically, what you see is granulomatous inflammation. However, there is a necrotic center, and that's what is forming the cheesy-like substance that you see grossly. Otherwise, the findings are typical of granulomas, which I talk about in another video. There's a ring of lymphocytes and macrophages surrounding epithelioid cells and giant cells, which are fused activated macrophages. Here's a picture of a lung that was infected with tuberculosis, and you can see why it's called caseous necrosis. This area of necrosis looks like cottage cheese. And here's an example of a caseating granuloma under the microscope. You have this ring of lymphocytes around the outside. In the middle, you can find epithelioid cells and giant cells, but importantly, you have this area of necrosis. It's just pink material in the middle, and that is what contributes to the caseous cheese-like finding on gross pathology. Fat necrosis, as the name implies, is necrosis of fat, and the classic example of this is acute pancreatitis. In acute pancreatitis, lipase enzymes are released from pancreatic cells. These are enzymes that normally travel to the digestive tract to break down lipids, but in acute pancreatitis, they leak and begin to damage the pancreas itself. One thing they do is break down peritoneal fat, and that peritoneal fat releases fatty acids which combine with calcium. This is a process called saponification. And this leads to formation of a chalky white tissue, which is classic in acute pancreatitis and fat necrosis. This is a gross specimen from someone who died with acute pancreatitis, and you can see these white clumps here. This is fat that has undergone saponification with calcium and undergone fat necrosis. A second place where you can see fat necrosis is in the breast, and this is a big problem for doctors who treat breast cancer and breast radiologists because this can mimic breast cancer. So women who have trauma to the breast can develop fat necrosis of the fatty tissue in the breast. Often this is after a biopsy or surgery on the breast, but it can also be from a sports injury or a seatbelt injury. And unfortunately, many women develop fat necrosis without recalling the injury because it didn't seem that bad at the time. And they will present with a lump that can mimic breast cancer, and it can be hard to differentiate this from malignancies of the breast. And this is a picture of fat necrosis of the breast, very easy to recognize under the microscope because of the big lobules of fat. Gangrenous necrosis is a subtype of coagulative necrosis, but it gets its own name because there's a characteristic way that tissues look when they undergo this type of coagulative necrosis. It's always caused by ischemia, and the two main places it occurs is in the limbs, especially the feet or toes, and in the bowel. These places can lose their blood supply and develop gangrenous necrosis. When there is ischemia to these areas, multiple tissue layers are involved, and it gives a characteristic appearance when you look at the tissue grossly. You can break down gangrenous necrosis into either dry or wet gangrene. In dry gangrene, this happens in the feet of people with peripheral vascular disease. The skin will be dry, but it will be black, and the tissue will be shrunken. I'll show you a picture of that in a minute. Wet gangrene is when dry gangrene has a superimposed bacterial infection. What's happening here is that you have the coagulative necrosis of gangrene, but also liquefactive necrosis from an infection. And as a result, the tissue looks moist, soft, and swollen. Because it's moist, it's called wet gangrene. There's often pus from the infection, and it's very foul smelling. If you ever see a patient with this, you will never forget because it smells horrible. So this is an example of dry gangrene. This is someone with peripheral vascular disease, and you can see how black the toes are. You can see that the skin tissue is pulled tightly together. This is dry gangrene. And here's an example of wet gangrene. So you can see that the tissue is swollen. It's also moist if you could touch it, and it would have a very foul smell. This is wet gangrene. Both types are caused by a loss of blood supply, but this type has a superimposed infection. Our last type of necrosis is fibrinoid necrosis, and this only occurs in blood vessels, and you can only see it under the microscope. There are no gross findings. The classic cause of fibrinoid necrosis is autoimmune disorders. In some autoimmune disorders, which I talk about in other videos, antibody-antigen complexes deposit in the vessel wall. This is an example of a type 3 hypersensitivity reaction. When this occurs, fibrin leaks into the vessel wall and gives a pink appearance on microscopy, and that's why this is called fibrinoid necrosis. And here's an example of what this looks like under the microscope. This is a blood vessel here. You can see the red blood cells, and there's pink material in the vessel wall. That is evidence of fibrinoid necrosis. You can see fibrinoid necrosis in a number of autoimmune disorders, but you should know, especially for step 1, that the classic disorder is polyarteritis nodosa. I talk about this in the video on vasculitis in the immunology section, but people with polyarteritis nodosa develop purpura on their skin, they develop renal failure, and they develop neuropathy. And the classic finding on biopsy of a blood vessel in a patient with PAN is fibrinoid necrosis. The other place you can see fibrinoid necrosis that you should know for step 1 is patients with severe hypertension or women with preeclampsia. In this case, it's not autoimmune like it is in polyarteritis. What's happening here is there's damage to the vessel wall and fibrin is leaking out, and that also can lead to fibrinoid necrosis. And that concludes our video on necrosis.